I'm going to call up Dr. Donofsky. He's going to talk a little bit about a study he did on HA fillers in the infraorbital area, but also on his technique of fat blocking.
Thanks, Jamil, and I want to echo the thanks to both the committee and to Drs. Marcus and Giacono for having us. So I've been doing fat transfer for about 9 years since I trained with the Glasgolds. This is a paper that we wrote on synthetic filler in the tear trough. With three-dimensional imaging, we were able to show at least about a year of durability in the tear trough with one particular HA filler. We do use Restylane. I know there was talk at a previous section about which HA filler. I feel like this one is predictable. It's not as hydrophilic as many, and therefore it's very predictable from a visual endpoint standpoint. So about a year durability. I will tell you that I had my tear troughs filled at the end of my fellowship, and at 6 years I had a touch-up. It was not a redo, it was a touch-up. We could tell with 3D imaging that it was still there, and it's been 9 years now, and with that touch-up I'm very, very happy with it. So I'm going to mainly talk about the fat transfer procedural details, and it's essentially as I was trained by the Glasgolds, who also took their technique from Sid Coleman, and break it down mainly into the different parts of the periorbital region. So, of course, the supraorbital rim, medial and lateral, the infraorbital rim, medial and lateral deep, and then superficial, anterior and lateral cheek, and then we frequently blend into the temple, sometimes the glabella. Although usually in the glabella, all we're doing is injecting the glabellar lines with a 22-gauge needle with fat. So advantages of fat, it's obviously natural, it's quite durable, there's no Tyndall effect. Sometimes to get a great result contour-wise in the tear trough, even in the best of hands you need to get a little more superficial, and you will get some Tyndall effect ultimately. There is less with Bellotero, I think, but you can still get it with that, I can promise you, if you go superficial. So fortunately that's reversible. Fat is not as reversible as Dr. Giacono and others have mentioned, and so certainly the pictures that were displayed of overfilling need to be in the back of our minds anytime we endeavor to do this. There may be a stem cell effect that's of course being worked on, and it's easily combined with other procedures. I would say most of the time I'm combining it with either a blepharoplasty or a facelift. So we use a 10 cc syringe, gentle back traction on that 10 cc syringe, 3 millimeter cannula. As we show here, there's only about 1 or 2 cc's of back traction, not more than that. I don't like to use the Luer locks, or the Johnny locks, excuse me. I just worry that will disturb the fat too much. The Glasgolds do it and say it doesn't really matter, but so that was how I was originally trained, and so I've stuck with this. So we do spin it. There's debate about how it's been shown that there's really no difference in processing. So there may be a slight tendency toward better preservation with Telfo rolling, but this is what I've stuck with. It's worked well. So after you spin it for 3 minutes at 3,000 RPMs, you discard this infranatant and supranatant, keep the good fat, which is this stuff in this slide here, transfer that from the 10 cc syringes into the 1 cc syringes, and then you're ready to go. We inject in multiple planes in small amounts. Quick video here if you wouldn't mind playing that, just to show kind of real time what the typical speed is of that. I'm not the world's fastest, but I do try to make sure that we're doing it carefully. And I'm holding with my non-dominant hand on the infraorbital rim, importantly feeling the rim and staying above that. And then go into the supraorbital rim. We can start either medial or laterally. In this case we started medially. I usually do about 1 cc medially and 1 to 2 laterally. Again, protecting with a non-dominant hand, feeling where we are, going up to and abutting the medial canthal tendon. But again, I don't like to hug the periosteum because of concern about intravascular injection. Good, skip the next one, please. So again, showing lateral approach. As others might have mentioned, you don't want to approach the infraorbital rim from the lateral approach. You can do anterior cheek from the lateral approach, but the supraorbital rim seems to be different, where you can do a threading. And the other important point for me anyway is to always inject on withdrawal. I never inject on advancement, again to minimize the chance of intravascular injection. And here we'll typically blend into the forehead and into the temple, and I'll make sure I get the lateral canthus, otherwise later on you'll see that you have a nice filling of the supraorbital rim and the infraorbital rim, and you've got a blank area in that canthus. So just some examples. I thought early on that I didn't see enough sort of numbers of what people will typically do in various patients, and so hopefully this will give you a good idea. This is pretty typical. I've been doing almost 10 years, and for the numbers that I'll use, and it's kept me out of trouble. So, patient with relatively mild atrophy, 1 cc medial and laterally along the deep infraorbital rim, 1 superficial, 3 in the anterior cheek, 2 in the lateral cheek. She already had pretty good definition in the lateral cheek, and then just 0.2 in the lateral canthus. And she also had a face and neck lift, deep plane facelift. Patient with more moderate atrophy, similar amounts in the infraorbital rim, deep and superficially, a little bit more lateral cheek because I didn't feel like as much definition laterally. And I also went to the temples in her with 2 cc's there and did her supraorbital rims. I think this is before blepharoplasty, but I ultimately did a conservative upper bleph on her. Again, moderate atrophy. Again, 3 cc's anterior and 2 lateral cheek in her case. A little bit more superficial. I felt like she was a little more gaunt in the infraorbital rim. And similar amounts, a little bit more laterally in her, 3 cc's. And again, 1 super and lateral supraorbital rim. I like to take at least 1 picture without flash, I feel like it shows the contours and highlights better. Sometimes when you take a frontal flash picture, it really fills all these hollows, and you sort of rob yourself of the improvement that you might have made. So more advanced atrophy, she has a pretty exposed upper orbital rim and pretarsal lid, and I would caution anyone about doing a brow lift in a setting like this, certainly, and then subsequently doing filling in the supraorbital rim. I think if you were to then lift the brow in this from this position after she's been filled, it would look pretty unnatural. So we did 2 cc's medial and lateral supraorbital rim in her for this more advanced atrophy. You actually get some nice lifting of the tail of the brow, I think, in this case, and without any actual direct surgical lifting. Wish I could have gotten a little bit better in her right supraorbital rim. She was initially deeper there, but we actually, one thing about this is you can go back in and touch it up with HA filler, and in this case we did subsequently. So, gentleman who was fairly thin, and I could only get a small amount of fat from him, and either way, with guys, you definitely want to be more conservative. You don't want to give the sculpted cheek of the more feminine approach. So did a lower blepharoplasty and only 3 cc's along the infraorbital rim, no anterior cheek or lateral cheek. Preserved his masculinity and got a nice improvement. He used to, patients had said that many people told him he looked like he was very tired and perhaps on alternative therapies, drugs. So, and this gentleman as well, so conservative lower lid transconjunctival bleph. Just a little bit of filling in the anterior cheek, just only 1.5 anterior, 1 lateral, and I'm glad I didn't do a drop more because he would seem to retain everything. So definitely conservatism, especially with guys. So in the future, will we use PRP and stem cells potentially to enhance these results? The early studies that have been done are somewhat encouraging, but as yet they're not convincing, and so I haven't started incorporating that yet. Animal models do show an improvement in the collagen thickness of the skin when fat transfer is done beneath the skin. So I think if you err on the side of conservatism, as mentioned by others who've spoken before me, I think you can have very happy patients. So thank you.